What's up, guys? Dr. Webb here. I'm an orthopedic spine surgeon here in San Antonio, Texas. And in this video, I'm going to be reacting to a YouTuber's recent video that he put out. I survived spine surgery. It is a video by Chad Wildclay. I had never heard of him until I came across this video today. And just wanted to give my thoughts as a spine surgeon. Let you guys know what I think about his journey and about his cancer diagnosis. So if you haven't heard, this YouTuber, who is a really popular YouTuber, he was found to have tumors on his back, and these tumors had to be removed because they were causing pain. Well, he put out a video kind of chronologically describing his journey and showing his journey about his recent spine surgery, and we're going to check that out and give my thoughts. Let's do that.
Film me getting back surgery.
Anytime we operate near the spine or near the nerve, there's a chance that we can damage those.
That's absolutely true. Anytime that we operate around the spine, the spinal cord, the nerves, the base of the brain, the brain, these are very delicate structures, and these structures can be injured with pressure, with retraction. And these structures can be injured by instruments and by devices that we place into the spine, such as spinal pedicle screws or cages that we put into the spine, and you distract it. If you distract it too much, that can put a lot of stretch on the nerve and cause some injury. So this is a conversation that I have with every single patient before surgery. And then I explain to them that damage to your nerves, you can have numbness, you can have tingling, you can have permanent damage. Your foot can become weak where you can't pick up your foot because of those nerves. And I explain that to them and let them know that's a risk of surgeries. Spine surgery in itself is very high risk, but when I saw this title that I survived spine surgery, I don't want this to create like a mass hysteria that patients can die from spine surgery, which they can. That's any surgery that patient undergoes. Of course you can die, that's a risk. But spine surgery or dying from spine surgery is very, very low risk.
The surgery is happening right now.
The bottom line is this most likely means that he's going to need radiation and maybe some type of chemotherapy.
Last week, I uploaded a video where I announced I have 8 tumors in my spine.
I've been dealing with a lot of back pain for about a year and a half now.
And this is a PSA. If you're dealing with back pain that is not resolved with conservative measures, anti-inflammatories, physical therapy, given some time, activity modification, you should go in and get evaluated. There are these so-called red flag signs that unexplained weight loss, if a patient has night sweats or fevers or chills, those are signs that advanced imaging studies such as an MRI should be undertaken to see what's causing that. It could be cancer, it could be infection, could be some type of tumor on the spine. It could be some serious conditions that you need to look into. Don't ignore those signs.
And it's finally time to try and fix it.
Today's the day for back surgery. Let's go to California.
For the last year and a half, if I've tried to jump, run, even walk, it's just felt like a knife has been stabbing me into my tailbone.
Leaving Las Vegas for the last time with a bad back. But I'm back. We're doing backflips. Right, me?
Good back chat.
Good back, Chad. The back he never had. I'm gonna get my back back.
It's been very painful to do anything physical. I'm hoping after this surgery that goes away. All right, time to prep for surgery tomorrow and go to bed because we got to get up at 4:30 a.m. to head over there.
The tumors are tumor. There's a pretty big one like here-ish, and they might want to remove this one later. This one, they say it's pretty dangerous.
The type of tumor that he has is called an ependymoma. This can be a really serious type of tumor that can spread throughout your whole body. And you can have multiple different types of these. There are different types. And when we're talking about tumors of the spine, we base them based off of their location. Is it inside the spinal cord or canal? Is it outside of the canal or on top of the spinal cord that's causing compression? So we base it off of anatomical locations. This type of tumor is usually inside of the spinal cord. So to access that type of tumor, to gain access to it, to remove it, you have to open up the spinal cord or the spinal canal and remove it. And this is typically done by neurosurgeons that specialize in this.
It's bigger, it starts touching nerves, I could lose access to my legs and stuff or whatever, so we're gonna have to keep an eye on this one. And then there's like 6 others inside the spine, so like you gotta get past the bone into the spine where the nerves are. And then the biggest one is like in the tailbone area. This is the one they're gonna remove. So they're gonna remove some bone, get in there, remove as much as possible. He said you might need to cut a nerve if you can't get it all, and I was like, don't cut a nerve, just leave it in there then. I don't know if that's the right decision or not. I don't know enough, I guess, but I don't want to cut a nerve. So then you could lose sensation in your leg.
So what does that mean? Does that mean the pain will still be there?
I don't know. I'll have to ask him tomorrow morning.
Yeah, I mean, some tumors that are evading structures that are very delicate, sometimes we have to sacrifice those structures, unfortunately. And some patients may have symptoms as a result of that, whether that's numbness as the nerve goes to sleep or does not wake up, or if that's, hopefully not a motor nerve where the patient is not able to move a body part because that nerve has been sacrificed. Well, we do have to remove that bone. That's called a laminectomy. We remove the bone to actually get down to the spine and to the spinal canal to remove that tumor. So he's absolutely correct.
5:15 in the morning. Woke at 2:30, woke at 3:30, and 4:30. All right, time to be up.
You had to drink 16 ounces of water this morning?
I actually drank 16.9. Hopefully that's okay. Very excited. As I walk, I feel the pain of my tailbone. Maybe this is the last time I'll feel that, Might be sweet.
He's actually really calm before a big operation like this, and I'm surprised that some patients are. Spine surgery is really high risk and has the potential to have a lot of complications from time to time, but he's actually taking it quite well.
I mean, I guess I'm worried, how long is the recovery gonna take? How painful is it gonna be? But it's fine. They'll give me painkillers. I feel bad for all the people who have to get up this early.
And then they called my name, and it was time to get prepared for surgery and put a tracking device on my wrist.
That's me. 9033. Let's go.
Alrighty, right this way.
Well, I know I'll
Put on some stylish gear.
So they gave me all the warnings about all the things that could go wrong. I figured it was just for safety reasons, and I assumed that none of this stuff would happen.
Anytime we're operating, there's always a chance that we could damage something.
But when he said loss of bowel movements, I was like, I hope that doesn't happen. It was pretty crazy how there's doctor after doctor coming in and telling me stuff and prepping me and giving me warnings.
I'm excited. Been dealing with this for about a year and a half. I'm ready for it to be over with.
I didn't like to hear about it's not going to be 100%, anything like that. I was like, oh man.
And that's just part of the conversation that we have with patients. I tell every patient before surgery, I can't make any guarantees that the surgery will be 100% effective, even though that we try to do everything in the ability that we can, the best ability that we can to, relieve pain and also relieve suffering. But at the same time, we're not God. We can only do the best job that we can. So I usually tell patients I'll try my best. I can't guarantee you that all of your pain will go away, but I will certainly try. That's sometimes all we can ask for.
There's just such high expectations that this is going to just put me back to 100% normal.
I would say it's not 100% since there is that thing's been there for a while, and it's probably caused some chronic damage to the nerves. I think the main question was that nerve thing that you brought up.
Yeah, I mean, if you want to leave tumor behind, we'll leave tumor behind. We'll save the nerve, just the high chance of tumor coming back, so most people only have that one lesion to worry about. You have multiple ones. This one is not the same as the rest of them, right? Because that's why it's growing the biggest. So when it's grown this big, it's got higher probability of it coming back quicker.
I see.
That's why it's bigger.
Well, I mean, I guess if it's just a sensory nerve that just causes a little bit of feeling, I guess that's fine. We have to.
I mean, that's the part that you cannot 100% predict how you're going to feel after.
Maybe still lean towards being conservative with cutting of nerves. I don't know.
We'll see what we can find there, okay?
All right. After over an hour of explaining the procedure and the possible risks, they wheeled me away to begin the surgery. Ready? Party time.
There are a lot of people in the operating room during surgery. There is the anesthesiologist, there's the surgeon, there's the OR nurse, there's circulator, the OR technician, there's the surgeon that is doing the surgery, but also the assistant, such as a resident or a physician assistant or first assist. And also there's what's called a neuromonitoring person or technician in surgery that monitors the nerves. And they will communicate with us in surgery to let us know if there's any nerve irritation. So this gentleman has a tumor on his nerves, and as you're removing that tumor, you have to be careful not to injure the nerve. So there's constant feedback from that neuromonitoring technician who is monitoring the activity of those nerves, and they will let us know, hey, you're pushing too hard, or there's a lot of activity or EMG activity that is going on right now. So we just basically try to chill, let it relax, take the pressure off the nerve, or just reverse anything that you've done. If you opened the spinal canal or distracted it with screws or instruments, maybe you'll relieve that distraction, or give the patient some steroids to kind of get things to calm down. So that's the cool and fascinating part about spine surgery. There's so many different avenues, the ways that we safely take care of patients, and there's so many people that are looking after patients in the operating room.
First major surgery. Okay. I'm doing good. I'm holding a pulse attention. I'm not even getting surgery. I'm such a mess. That's Chad. Currently in surgery right now. The surgery is going to be 5 hours long. So I am here, waiting.
That's one thing that I, can admit that I don't appreciate enough or give enough thought to is the families. What are they going through during the operation? Some of these operations can be 4, 5, 6, 7 hours, and sometimes the patients, they may not get any feedback of how their family member is doing, and their mother, their brother, their sister. And, some of them take it pretty hard, like this young lady here. So that's something I really never thought of until watching this video. And, just what is the family going through during this time while this patient is under? And, some people, they take it really well, and other people, they have a hard time.
The past year and a half, Chad has been in constant pain. His butt, his hamstring, you can always see him going like this and like that. So from here all the way down to his legs, he's in constant pain. And when he walks, he's in more pain. When he's sitting, he's in more pain. When he's running, he's in more pain. So when you see him in the videos, people don't even know it because he has this positive energy and he always has a smile on his face. So yeah, it makes me really sad to think that he's living in so much pain. So I'm very glad the surgery is happening right now. The tumor is going to be removed, so maybe he'll be Giga Chad. Yeah. So I was thinking about the surgeon, and like sometimes I just want them to say, yes, doing the surgery will 100% improve the pain that Chad's having, but they can never say that because you just never know what's gonna happen. Hello, hi, this is V.
Yeah, hi, V. It's Dr.
Oh, hi, Dr.
We're all done with surgery, essentially. Just holding up the skin, and we're going to wake him up, okay? The surgery went fine for the most part. There's no major issues. It's consistent what I was worried about from the very get-go, that this was a tumor. It was all wrapping around the nerve roots and invading into it, so it wasn't coming from one specific nerve root. The bottom line is this most likely means that he's going to need radiation and maybe some type of chemotherapy delivered given to him. Probably got somewhere around 50 to 60%, if that, okay?
That's it?
Because it's all wrapping around the nerve root. When I try to do more, there's clearly nerve irritation. There's already signs of nerve change. But we'll get an MRI, we'll see. It may be more than that, but it really doesn't ultimately matter that much, only because...
That's typical of doing surgery for tumors. Typically, you'll try to debulk the tumor or remove the entirety of the tumor, all of it, and then there are cells, macroscopic, sometimes microscopic cells that are left behind, those tumor cells, and then you target the rest of what's left behind with either chemotherapy or radiation if that tumor is radiosensitive or if it responds to chemotherapy. So there's certain tumors that are radiosensitive that we can use radiation. The radiation will induce like DNA apoptosis to stop the cell from proliferating or dividing or enlarging in size and numbers. And there's chemotherapy that has multiple different mechanisms of action, but ultimately to stop the cell from growing.
That's yours for the HBOC. I'm sorry, we come back in about an hour and a half.
Okay. Okay, all right. Okay,
Take care, okay?
Thank you. Thank you.
Well, look who's here.
How are you feeling?
Good, pretty good.
Yeah?
You be careful with that catheter.
Oh.
You're clumsy. I don't want you tripping on anything.
Oh my gosh, you have a catheter?
Yep.
Oh no.
I guess it went well.
Yeah.
They had to use like some radiation.
Uh-huh.
But then like a spider got in there and came in and bit me. So now I have like superpowers.
Oh, you're Spider Chad.
Yeah.
You'll notice that he's laying flat. And that's usually the protocol after cases like this. Or if a patient has a spinal leak during surgery, typically we'll try to repair what's called dura, or the outer covering of the thecal sac or the spinal canal. And because of that repair, you want to protect it. And the best way to do that is keep patients flat. And that way the repair will heal itself and give it time to heal, and also so it takes the pressure and stress off of your repair site. So if a patient has a spinal leak, either incidentally or iatrogenic during surgery, or if it's part of the procedure, like in this case, they had to open up the spinal canal, then spinal fluid leaks out, well, you have to repair it, and then you want to protect your repair site by keeping the patient flat for sometimes 24 to 48 hours.
Just stop moving your neck, please.
Okay.
Just chill. It says flat. That's...
So it's time to get another MRI and see how much of the tumor actually got removed on the scan.
I hope MRI doesn't stand for mass rectal inspection.
They had to move me from the bed into the MRI machine while keeping me flat. So they got out like this flat board and had a bunch of nurses just like pull me over. It was pretty tough.
2 bumps here, my man.
Ooh.
Second one, 1, 2, and 3. Take your come size.
Day number 2. Just been laying here flat. Can't get unflat. Get your catheter out. I was like, no. For those of you who don't know, it's a one tube going into your pee-pee. And it hurts. So I gotta pee in this.
What?
So that's what he's talking about. It's called a Foley catheter. That is when we have longer surgeries or if a patient will be immobilized for prolonged periods of time, there's a little tube catheter that goes into your bladder to drain your urine during surgery or after surgery. So it's called a Foley catheter.
Yeah, I'll definitely do that.
Yeah.
VIP suite.
And then the surgeon who performed the surgery came in to give me some news.
So, are you okay?
I am feeling a little bit of the normal hamstring pain. I'm wondering if maybe it's just inflamed a little bit and that might still go away. It's just
From a different area.
I said, oh, from a different tumor. Oh, dang. Is it the top one up here?
I can't tell you.
Oh.
You have multiple.
Man.
This S1-2 nerve won't get down there. It's just, that's what it's the buttocks and the feet.
So I might be coming back to see it again in the future.
No, you don't want that.
No, just deal with it.
No, that's where the radiation might help.
Oh.
We're still going to treat the tumor, it's just going to go radiate the whole area.
Oh, cool. So even if it's not cancer, still do radiation?
If it's a ependymoma, it is something that still probably is going to require radiation. It will require radiation.
Oh, okay.
Definitely a tough situation to be in. Young person who was relatively healthy prior to this, and you've been told that you have cancer and have to undergo radiation and chemotherapy. That's life-changing.
I know at first you were thinking maybe it's like brain cancer, it's not that.
It's what I told you the first time, what I thought it was. It's ependymoma.
Ependymoma. Is that pretty rare or pretty common?
I mean, it depends on who you ask.
I wonder what causes it. That's so weird. Probably because I drink too much Fresca.
I mean, people can be paralyzed and die from this. Because the tumor grows too big, severely compressing the spinal cord, or it's spread all along the brain and spinal cord. It causes nerve damage in the brain and spinal cord. So that's why you can't ignore the radiation chemotherapy part of it if it's appropriate. All right,
Thanks for stopping in.
Thank
take
you.
care, okay?
Thank you.
Bye-bye.
So it sounds like I have to get radiation, no matter what.
It does seem like that.
The mold, it's not male pattern molding, okay?
But if that shrinks these things down, probably means less pain, so it's worth it. But it's probably more unhealthy for your body to get radiation.
Your spinal precautions are like a BLT sandwich. You can't bend, so no bending like this, or no bending like this past 90 degrees. You can't lift anything greater than 10 pounds, and no twisting.
No twisting.
That's the T.
These are just general post-operative restrictions or activity modifications that we tell patients who have spine surgery or undergo spine surgery. No BLT, bending, lifting, or twisting.
Man, I just had back surgery days ago, and now I gotta do physical therapy. The part in my back where they cut me open really hurt so much. My spine is still healing. How am I gonna even be able to get up?
For the results to come back. So then once we have the report, then we can get you set up with an oncologist about the next steps of treatment.
Okay, great.
Yeah. So we want you to continue treatment. We just don't know what yet until we know exactly what it is.
Yeah.
The tumor or mass lesion is removed from whatever part of the body. You have to send it to a pathologist. That pathologist will confirm what that is. And once you get the results back, you can base your treatment off of that, whether that's chemotherapy or radiation or active surveillance, which means we just watch it over time.
I'm just being paranoid because, like, well, how did I get these 8 tumors? Got my ID. I'm back to normal now. Got my back brace on. They said if I fall, I can't leave, so I got to make it out here without falling. All right, Lee, test your technique. Ready? B, I'm falling.
Hug and lift.
Oh, thank you.
Okay.
Saved my life.
So, how do you transport a guy who just had spine surgery back to Las Vegas in one piece? Well, you need a bed on wheels.
It's nice in here.
I actually never thought about that. That at RV, patients can actually lay down flat on the bed, which you can't do on an airplane, really can't do in the car. Man, that's a brilliant idea. I'm wondering why other patients who have had surgery hasn't really thought of this. That's actually a really good idea.
Woo, party! Road trip. Alright. Ready for a road trip back to Las Vegas.
Yeah. Look at him. Barf bag ready?
Yeah, I feel pretty sick.
That's
We haven't
good.
started driving yet, but
Oh man.
I think I took too many medications.
Now. It's been about 5 hours in this RV.
Bumpy, nauseous, had a puke bag with me, but I didn't have to use it, so. Man, I probably should have took a plane.
I thought it was a
That was like 7 hours, wasn't it? We left at what, 2:30?
2:30.
What time is it now? At 11? That was crazy. Let me in, neighbors.
One more step.
Wow, that's actually a really good kind of video, kind of showing his journey along this his spine surgery kind of path, and you know, those are my thoughts. Really serious condition, spine tumors. I don't see them a lot in my practice. I see them from time to time, but this is one of those things that you know, once you see it, these are serious conditions that patients can die from. They can become paralyzed. But with the advent of, you know, the technology these days, we can detect these tumors kind of earlier, and patients can get treated successfully you know, a lot sooner. Radiation's better these days, chemotherapy, the drugs that we use with less kind of side effects. So, but I wish him well in terms of his journey as he goes off to do chemotherapy and radiation. But here, these are my thoughts as a spine surgeon. I hope you guys enjoyed this video, and we'll see you next time.